All right, I am back. Let us continue. If you can hear me clearly, raise your hand. Okay, that's good enough. All right, the next chapter we are going to cover is face and neck injuries. And with face and neck injuries, what you need to be concerned about is airway complications and head and spine complications in a nutshell. Let's get into it. Introduction. The face and neck are vulnerable to injury. It is relatively unprotected. Soft tissue injuries and fractures are common and they vary in severity. Some injuries are life-threatening. Penetrating trauma to the neck may cause severe bleeding, and it may also compromise the ear passage. An open injury to the neck may result in an ear embolism. With appropriate pre-hospital and hospital care, a patient with a seemingly devastating injury can have a very good outcome. Now let's review the anatomy involved in these injuries quickly. Cranium. So we're looking at the head. The cranium contains a brain. Most posterior portion is called the occiput. Lateral portions on each side are called the temples or temporal regions. The forehead is called the frontal region. Anterior to the ear is the temporal region. You can feel the pulse of the superficial temporal artery. That's just anterior to the tragus of the ear. The face is composed of the eyes, ears, nose, mouth, and cheeks. 6 major bones include the nasal bone, 2 zygomas, 2 maxillae, and mandible. The orbit of the eye is composed of lower edge of the frontal bone of the skull, the zygoma, the maxilla, nasal bone. And the main goal of the orbit is to protect the eye from injury. Only the proximal third of the nose is formed by bone. The other portion of the nose consists of cartilage. The exposed portion of the ear is composed entirely of cartilage covered by skin. So you have the pinna, the tragus, superficial temporal arteries. About 1 inch posterior to the external opening of the ear is the mastoid process. The mandible forms a jaw and chin. Motion of the mandible occurs via the temporomandibular joint. Now for the neck. The neck contains many important structures supported by the cervical spine. The upper part of the esophagus and the trachea lie in the midline of the neck. The esophagus is posterior and it goes to the stomach. Trachea is anterior and it goes to the lungs. The carotid arteries are found on either side of the trachea, and these arteries supply the head or brain with blood. The larynx, Adam's apple, is located in the center of the neck. Other portion of the larynx is the cricoid cartilage, which is the only cartilage in the sorry, it's the first cartilage in the trachea to form a complete ring. The laryngeal prominence is the Adam's apple. Then you have the thyroid cartilage, and then the membrane below that, cricothyroid membrane, and then the cricoid cartilage is below the cricothyroid membrane. The trachea below the larynx connects the oropharynx and the larynx with a main passage, with the main passages of the lungs. The sternocleidomastoid muscles originate from the mastoid process and allow movement of the head. Now the eye. The eye is globe-shaped, approximately 1 inch in its diameter, and it is located within a bony socket in the skull called the orbit, and majority of the eye is protected by the orbit, 80%. So that diagram showing the layout of structures within the eye. Clear jelly-like fluid near the back of the eye is called vitreous humor. In front of the lens is a fluid called the aqueous humor, which can leak out in penetrating injuries. The conjunctiva is a membrane that covers the eye. The lacrimal glands produce fluid to keep the eye moist. The sclera is a white fibrous tissue that helps maintain the globular shape of the eye. On the front of the eye, the sclera is replaced by a clear, transparent membrane known as the cornea. And the cornea allows light to enter the eye. The iris is a circular muscle behind the cornea. The pupil is the opening in the center of the iris that allows light to move to the back of the eye. Anisocoria is a condition in which a person is born with different sized pupils. The lens lies behind the iris and it focuses images on the retina at the back of the globe. And the retina is a very important structure to our ability to see. So think of the retina as the link between the eye and the brain. So it's that nerve link between the eye and the brain. If the retina is detached, the person is going to lose their ability to see. So the retina contains nerve endings. It responds to light by transmitting nerve impulses through the optic nerve to the brain. The retina is nourished by a layer of blood vessels called the choroid. Retinal detachment causes blindness. Now, injuries to the face and neck. So that was a review of the anatomy and physiology. Let's look at the injuries. Injuries to the face. Injuries of the face and neck can often lead to partial or complete obstruction of the upper airway, which I mentioned before we started the chapter. Your most significant concerns will be with airway and spinal complication. Several factors may contribute: blood clots from heavy facial bleeding, direct injuries to the nose and mouth, larynx and trachea, dislodgement of teeth or dentures into the throat. Swelling that accompanies direct or indirect injury, so swelling can be a problem. Airway may be affected when the patient's head is turned to the side, possible injuries to the brain and or cervical spine. Now, soft tissue injuries, very common. Face and neck are extremely vascular, so they can bleed a lot. Swelling may be more severe. Skin and tissues in these areas have a rich blood supply. A blunt injury can cause a hematoma, and at this point we know what an hematoma is. So once you say the word hematoma, it means a large blood vessel is bleeding in the area, or an arterial blood vessel. Dental injuries. Mandible injuries are common. Most of these injuries are the result of vehicle collisions and assaults. Signs of mandible fracture include misalignment of the teeth, numbness of the chin, and inability to open the mouth. It is extremely painful if the mandible is fractured. So a broken jaw is extremely painful, and it takes a lot of force to crack the mandible. So you should be thinking about head injuries. Maxillary fractures are usually found after blunt force high energy impacts. Signs of maxillary fractures include massive facial swelling, instability of the facial bones, misalignment of teeth. Fractured and avulsed teeth are common following facial trauma. Now the patient assessment. Perform your scene size up, observe for hazards and threats, assess for potential violence and environmental hazards. Eye protection and face mask are standard. Carry several pairs of gloves. And I don't know how it works now in the field. So back in the days when I was riding ambulance in Jamaica, it was one box of gloves. In a first world system, each responder has their own box of gloves, and it's the size that you prefer. So we all have our own box of gloves once we start the shift. I know it's not like that, no, but always keep more than one pair of gloves on you. Determine the number of patients. Mechanism of injury or nature of illness. Assess the scene. Common MOI for face and neck injury, motor vehicle collisions. Sports. So it's very common in sports, especially contact sports. Falls, penetrating trauma, blunt trauma. Once we have completed the scene size up, the next phase of the assessment is your primary assessment. Focus is on identifying and managing life-threatening concerns. Threats to ABCs must be treated immediately. By now, we should have that mindset. When there is a life-threatening external hemorrhage, it should be addressed before airway and breathing. Form a general impression of the patient and the environment. Look for important indicators about the seriousness of the patient's condition. Injuries may be very obvious or hidden. Control blood loss with direct pressure. Consider the need for manual spinal stabilization. Check for responsiveness using your AVPU scale. Then assess and manage airway and breathing complications if present. So ensure a clear and patent airway. The patient is unresponsive or has significantly altered LOC, then you need to consider the use of an airway adjunct. We will not consider the use of an airway adjunct until we have confirmed all three indicators. So there are three indicators for the OPA, three indicators for the NPA. Until you have confirmed that, you shouldn't be using an airway adjunct. Quickly assess for adequacy of breathing. And when we're assessing breathing, we look at rate, rhythm, quality, and depth. Palpate the chest wall for decap BTLS. Splinting or otherwise restricting chest wall motion is contraindicated. In the circulation assessment, so after breathing, next is circulation. So quickly assess pulse rate and quality. If the patient is talking to you, peripheral pulse. They are not central. Determine skin condition, color, temperature, check cap refill time, especially in your pediatric population. Check for bleeding. After you have completed your ABCs, you should know what your patient's GCS is at this time. You should know if you need to do a rapid scan or focus, and you should know if this is a stay and play or load and go patient. So consider quickly transporting patients with airway or breathing problems or significant bleeding. Consider ALS backup. A patient with internal bleeding must be transported quickly for treatment by a physician. Signs of hypoperfusion that you need to be looking out for: tachycardia, tachypnea, low blood pressure, weak pulse, cool, moist, pale skin. Even if the patient has no signs of hypoperfusion or other life-threatening injuries, there is a possibility of eye injuries. Patient should be transported as quickly and safely as possible. Surgery will need to be accomplished within 30 minutes or permanent blindness may result. After the primary assessment, the next phase is your history taking. If the patient is communicating, we want to get that information first, then we move into the secondary. Patient is not talking to you, then you want to consider your vital signs, and if you can get any information from persons present, and look at what the patient is telling you physically. So investigate the chief complaint, obtain a medical history, be alert for injury-specific signs and symptoms, be aware of your pertinent negatives, get a sample history from the patient or from friends and family. Your secondary assessment, physical examination. If multiple systems have been affected, start with an assessment of the entire body, looking for DCAP BTLS, IC. Do not delay transport to complete a thorough physical examination. In a responsive patient with an isolated injury with limited MOI, consider focusing on the isolated injury and the patient's chief complaint and the body region that is affected. Ensure that control of bleeding is maintained and note injury location. Inspect the open wound for any foreign matter and stabilize impaled objects. Use both your eyes and your hands. Assess all underlying systems. When evaluating the eyes, start with the outer aspect and work towards the pupils. Examine the eye for any obvious foreign matter. Visual acuity is a vital sign of the eye. Can they follow the fingers in a H pattern? Is the pupil adjusting when you bring the fingers close or when you move it away? What is a pupil reaction? So really check the eyes. Look for discoloration, bleeding, redness, eye symmetry, and pupil size and reaction to light. Brain injury, nerve disease, glaucoma, and meningitis are causes of unequal pupils. Vital signs. Assess vital signs to obtain a baseline. You want to consider the patient's level of consciousness. You check the pupils. You check the respiration with pulse oximetry and end-tidal CO2 if it's available. You check the pulse, check the blood pressure, you check the GMR. That's your vital signs. And you compare them to the previous findings in the primary assessment. In your reassessment, repeat the primary, reassess vital signs, and the chief complaint. Reassess the patient's condition at least every 5 minutes. Interventions provide complete spinal immobilization or spinal motion restriction if necessary. Now let's look, oh, not there yet. Maintain an open airway, be prepared to suction, and consider an oropharyngeal airway. Whenever you suspect significant bleeding, provide high flow oxygen, control significant visible bleeding. Now let's look at emergency care. Still not there yet. If the patient has signs of hypoperfusion, treat aggressively for shock, provide rapid transport. During the reassessment phase, you're also doing your documentation. So you need to call the receiving facility, let them know what you're coming in with, and you need to document appropriately and make sure that you hand over properly when you get to the receiving facility. Now, emergency medical care. Treat soft tissue injuries to the face and neck the same as soft tissue injuries anywhere else on the body. So it's the same approach. Ensure that you address any life-threatening complications to airway, breathing, and circulation first. Follow the appropriate standard precautions. In the absence of life-threatening bleeding, first open and clear the airway. Make sure your patient's airway is clear. Avoid moving the neck in patients that you suspect have cervical complications or cervical spine injuries. Control bleeding by applying direct pressure with a dry, sterile dressing. Use a roll of gauze wrapped around the head to hold pressure dressing in place. And when you're bandaging the head, you don't want to wrap too tight. You want to wrap enough to keep the dressing in place, but not too tight because swelling may occur. So you have to kind of leave some room for swelling to occur. Do not apply excessive pressure in an underlying skull fracture. Sorry, if an underlying skull fracture is suspected. Cover exposed brain. Don't try and put it back inside the patient's skull. So cover exposed brain, eye, or other structures with a moist, sterile dressing. So if the brain tissue or the part of the eye that's supposed to be in the orbit is exposed, then you want to use a moist, sterile dressing. Apply ice locally to injuries that do not break the skin. For soft tissue injuries around the mouth, check for bleeding inside the airway. Broken teeth or tongue lacerations may cause extensive bleeding and obstruction of the upper airway. Physicians can sometimes graft a piece of avulsed skin back in position. If you find portions of the avulsed skin, wrap it in a sterile dressing, place it in a plastic bag, keep cool, but do not place directly on ice, and label and deliver to the emergency department. If the avulsed skin is still attached in a loose flap, place the flap in a position as close to normal as possible and hold it in place with dry, sterile dressing. Now, injuries specifically to the eyes. Eye injuries are common, particularly in sports injury, can produce lifelong complications including blindness. In a normal uninjured eye, the entire circle of the iris is visible. The pupils are round, usually equal in size, and they will react to light. And when the left pupil reacts, the right pupil also reacts to light at the same time. After an injury, pupil reaction or the shape of the eye and how the eye moves will be disrupted. So you might see the eyes not moving together, or they have a unusual gaze, like an upward gaze with one of the pupils. Treatment starts with a thorough examination. Always use standard precautions. Take care not to aggravate any problems. Look for abnormalities or conditions that may suggest the nature of the injury. Foreign objects. Even a small object may produce severe irritation, and at some point, majority of us have experienced that. An eyelash getting into the eye, and you think it feels like gravel or stone is in the eye. Irrigation with a sterile saline solution will frequently flush away loose particles. Use a bulb syringe or a nasal airway or a nasal cannula. So we can use a bulb syringe for flushing, we can use a nasal airway, or we can use a nasal cannula. Always flush from the nose side of the eye towards the outside to avoid flushing material into the other eye. So when flushing, the main thing is to avoid cross-contamination. A foreign body will leave a small abrasion on the conjunctiva. Gentle irrigation may not wash out foreign bodies stuck to the cornea or lying under the upper eyelid. So we may have to use a Q-tip, wet that with some saline and try to get the object out. Foreign bodies may be impaled in the eye. If there's a foreign body impaled in the eye, we're not going to try and remove it. We're going to try and secure it in place with bulky dressing or a donut style dressing. And we can use you can use a triangular bandage to create a donut. We can play around with that in the face-to-face session. So donut goes over the object to keep it stable, and as long as there's no contraindication, you transport these patients in a supine position, and you want to cover both eyes because the nerves work together. So if the good eye is moving, the injured one will move as long as the nerves are intact. So we want to limit that movement of the injured eye. Burns of the eye, stop the burn and prevent further damage. For chemical burns, usually caused by acid or alkaline solution, flush the eye with water or saline. Direct the greatest amount of irrigation solution of water into the eye as gently as possible. I have various methods for irrigating the eye. Whichever your organization approves, work with it. Chemical burns. You may have to force the lids open. Flush from the inner to the outside corner. If the burn was caused by an alkali or a strong acid, irrigate continuously for at least 20 minutes. After irrigation, apply clean, dry dressing to cover the eye and transport. For your thermal burns during a fire, the eyes will close to protect from heat and the eyelids will burn. Transport promptly without further examination. Cover both eyes with a sterile dressing, moisten with sterile saline, apply eye shields over the dressing. And these patients should be transported supine unless contraindicated. That will relieve the pressure inside the eye. So when you're upright, the pressure is higher. the intraocular pressure is higher than when the patient is lying supine. So we want to reduce the intra light. Okay, connection giving a little issue. All right, light burns. Infrared rays, eclipse light, and laser beams all can cause significant damages. Retinal injuries caused by exposure to light are generally not painful, but may result in permanent damage. Severe conjunctivitis, which is inflammation of the conjunctiva, usually develops with redness, swelling, and excessive tears. Lacerations require very careful repair to restore appearance and function. Bleeding may be heavy, but it usually can be controlled with gentle manual pressure. If there is a laceration of the globe itself, apply no pressure to the eye. Never exert pressure or manipulate the injured globe. If part of the eyeball is exposed, gently apply moist, sterile dressing to prevent drying. Cover the injured eye with a protective metal eye shield cup or sterile dressing. Apply soft dressings to both eyes and provide prompt transport. On rare occasions, the eyeball may be displaced from its socket. Do not attempt to reposition it. Cover the eye and stabilize it with moist, sterile dressing. Cover both eyes to prevent further injury and have the patient lie supine. For blunt trauma, injuries range from ordinary black eye to a severely damaged globe. High FEMA, which is bleeding in the anterior chamber of the eye, obscures all parts of the iris. An orbit fracture is a fracture of the bones that form the eye floor and support the globe. Retinal detachment is often seen in sports. The following findings should alert you to the possibility of a head injury. If there is unequal pupils, should be thinking about a head injury. If the eyes don't move together, should be thinking about a head injury. If they are not able to follow your fingers, should be thinking about head injury. If there's bleeding under the conjunctiva or there is protrusion or bulging of one eye, then you should be thinking about a head injury being present. For blast injuries, signs and symptoms range from severe pain and loss of vision to foreign bodies within the globe. If there is a foreign body within the globe, do not remove it. If only one eye is injured, follow local protocol. If the patient has severe swelling, do not force the eyelid open to examine it. For contact lenses and artificial eyes, do not attempt to remove contact lenses unless there is a chemical burn. Remove a hard contact lens, use a small suction cup. To remove soft contact lenses, place 1 or 2 drops of saline in the eye, pinch the lens between the thumb, index finger, and then lift. Now, injuries to the nose, nosebleeds, or epistaxis are common problems. One of the most common causes is digital trauma. Anterior nosebleed usually originate from the area of the septum and bleed slowly. Posterior nosebleeds are usually more severe and often cause blood to drain into the throat. So the posterior nosebleed can compromise the airway. The nose often takes the brunt of physical assaults and car crashes. Blunt injuries may be associated with fractures and soft tissue injuries of the face, head, neck, and spine. Assess the nose structures for injury. It is helpful to picture the inside of the nose. Cerebrospinal fluid may escape down through the nose following a fracture at the base of the skull. Control bleeding by applying a sterile dressing. Injuries of the ear. The ear is complex and associated with hearing and balance. Divided into three parts: the external, middle, and inner ear. The ears are often injured, but they do not usually bleed very much. In case of an ear avulsion, wrap the avulsed part in a moist sterile dressing and put it in a plastic bag. If the tympanic membrane ruptures, sudden changes in pressure created by a blast wave may cause rupture. It can also be from trauma, where pressure is generated in the ear canal. Sudden pressure. Patients will report severe ear pain, difficulty hearing, and ringing in the affected ear. It may be caused by insertion of objects too far into the ear. Transport to the hospital for evaluation. Children place foreign bodies in the external auditory canal. Clear fluid coming from the ear may indicate a skull fracture. For your facial injuries, typically result from blunt force trauma. Assume a direct blow to the mouth or nose has caused a facial fracture. Other clues to look for: bleeding in the mouth, if the patient is having trouble talking or swallowing, if they are missing teeth or loose teeth, and if there are bony areas that can be moved or it feels loose when you palpate the area. Facial fractures alone are not acute emergencies unless there is serious bleeding. Plastic surgeons can repair the damage to the face and mouth if the injuries are treated within 7 to 10 days. Swelling can be extreme within the first 24 hours after injury. Now, dental injuries can be traumatic to the patient. Bleeding will occur whenever a tooth is violently displaced from its socket. Apply direct pressure to stop bleeding. Perform suctioning if necessary. Cracked or loose teeth are possibly airway obstructions. Save and transport an avulsed tooth. Handle it by the crown rather than the root. Place it in a storage solution. Whole milk or sterile saline. Can use the patient's saliva as well. Notify the hospital. Reimplantation is recommended within 20 minutes to 1 hour after the trauma. Injuries of the cheek. You may encounter an object impaled in the patient's cheek. If you are unable to control bleeding, consider removing the object. Then provide direct pressure on the inside and outside of the cheek. The amount of bandaging should not occlude the mouth or ear passage. For injuries to the neck contains many structures that are vulnerable to blunt force trauma. The upper airway is at risk, the esophagus can be damaged, the carotid arteries and jugular veins, the cartilages in the neck, and of course the trachea, the windpipe can be damaged itself. Blunt injuries, any crushing injury of the upper parts of the neck is likely to involve the larynx or trachea. Once you suspect a crush injury to the neck, you definitely need to be thinking about airway management from direct impact and secondary spinal complications. Once the cartilages of the upper airway and larynx are fractured, they will not return to their normal position. Blunt injuries can lead to loss of voice. Patient can complain of difficulty swallowing. There is severe and sometimes fatal airway obstruction and the leakage of air into soft tissues of the neck. So they can get something that is referred to as subcutaneous emphysema, which the air is leaking out and it's going to be in the upper part of the chest. That's where you're going to feel it. Kind of feel the same as crackles. And I always tell students that crackles feel like Rice Krispies to me. The Rice Krispies treat, snack, that's what crackles feel like to me. Complete airway obstruction can develop rapidly. ALS support, either by ear or intercept, may be necessary. So this patient is definitely a patient that will require emergency management. Penetrating injuries to the neck can cause profuse bleeding from laceration of the great vessels in the neck. Injuries to the carotid or jugular vein can cause exsanguination. That's basically the patient bleed their entire blood volume out. Injuries to these large vessels may also allow air to enter the circulatory system, which can lead to an ear embolism and cardiac arrest. Direct pressure will control most bleeding, but your goal is not to bandage circumferentially. So we do not bandage the neck circumferentially. We have to create an angle when bandaging the neck. We will go over that when we cover the face-to-face skills sessions. Laryngeal injuries. Blunt force trauma to the larynx can occur when unrestrained driver strikes the steering wheel. So it's kind of like a clothesline. Snowmobile rider strikes a clothesline. The larynx becomes crushed against the cervical spine, resulting in soft tissue injury, fractures, and the separation of the fascia, which is the membrane that is around the muscle. Penetrating or impaled objects in the larynx should not be removed unless they are interfering with CPR. Stabilize all impaled objects if they are not obstructing the airway. Signs and symptoms of larynx injuries: respiratory distress, hoarseness, pain, dysphagia, cyanosis, pale skin, sputum in the wound. Subcutaneous emphysema, bruising on the neck, hematoma, bleeding. To manage a laryngeal injury, provide oxygen and ventilation if necessary. Apply cervical immobilization, but avoid rigid collars. Right? Very important points there. So if you suspect laryngeal injuries with cervical complication, we're not going to put on a rigid collar. It's going to be more of a soft collar. Do you have a question, Mr. Duhaney?
Yes, sir. If a patient's throat is crushed, or they receive an injury toward their throat area, but they are
Mm-hmm.
conscious, but we can't like they can't speak. Like, oh, would we approach the lock? Like, would we be like, sir, blink or move your fingers if you can, like say, yeah, like use code, like lift, like blink twice if no, or blink once if yes. Like, would we have to use codes like that if the patient can't talk, but we can sense that, hey, this patient is conscious, but we need to know certain things, certain questions just to make sure of certain things. Is codes applicable in that situation?
As it relates to the codes, you use whatever can give you a response. So it doesn't have to be the you using code specifically to get a response. It depends on what the patient can and cannot do. The patient can write, let them write, right? So it doesn't have to be specific to the codes. It depends on the circumstances and what the patient can and cannot do. The most important thing for that patient is they can understand you, right? So if you want to call it codes, fine, but at the end of the day, it is not the EMT responsibility to make up codes for these type of injuries. It is the role of a medical director. So if the medical director decides that, okay, if we have a patient in which the airway is so significantly compromised that they can't communicate, these are the steps that we are going to follow, right? Find out if they can write, they can't write, then do this. If they can't do this, do. So that's something that should come from your medical control. That's not for you to determine on a emergency scene, right? Because we do not operate independently, right? So if the medical control want to say use codes, fine. They want to call it codes, fine. They don't have to. They can say for step one, find out if they can write. Step two, they can't write. Find out if they have the ability to blink. If they have the ability to blink, one blink represent whatever. So it doesn't necessarily have to be a code, because code is usually numbers, 10-4, 10-2, right? So codes would be numbers. So it doesn't necessarily have to be a code, right? And that would be the end of this chapter. It's a lengthy chapter, but at the end of the day, the focus is on two things: risk of compromise to the airway and cervical injuries. So your primary concern, if there's direct impact, is going to be, is the airway compromise. Secondary is the spine compromise. And your treatment must always be geared towards that. Some injuries require specific type of dressing, like moist dressing. So you have to pay close attention to that, right? So once you find an injury where the approach is outside the norm, you need to ensure that you commit that to memory. So if it's a injury that requires moist dressing, that's something that you definitely need to commit to memory. If it's an injury in which you suspect C-spine issues, but you're supposed to be using a soft color, then you need to commit that to memory. So you need to commit the important variations. The standard management for soft tissue injuries is always going to be direct pressure, elevation with your dressing, secure with your bandages, last resort, tourniquet. But there are some injuries that require specific dressings or a specific approach. So you have to pay close attention to that when you're studying the chapters. All right, now question 1. Which of the following statements regarding the Adam's apple is false? taking too long to answer this question. Shouldn't be taking that long. All right, so this is a question that is very straightforward. Answer would be apple. All right, question number 2. The globe of the eye is also called the globe. It never said the bony prominence, okay? Said the globe. All right, good. So that would be correct. D as in dog. Number 3. When a person is looking at an object close, so when an object goes close to the eye, does it constrict or dilate? Work out the maths now. When you bring an object close to the eye, does it constrict? Does the pupils constrict or does the pupils dilate? Think about it carefully. If I have a pen light and I shine it into the patient's eye, that light is very close to the eye, yes? What happens to the pupil? Okay? And if I start to move that object away, the pupil will adjust accordingly, right? So the answer would be B, B as in boy, right? B would be correct. All right, number 4. Oh, forgot that I don't record.